Thank you for taking the time to attend our presentation, How to Overcome Patient Identity Challenges. Our speaker today is Michelle Schneider. Michelle is a solutions engineer with IATRIX Systems, focusing on the interoperability needs of hospitals, networks, regions, and states. Michelle has participated in EMR implementations and conversions, HISP and HIE implementations, EMPI management, and interface management and testing. She's a registered nurse committed to the mission of educating the healthcare community about interoperability as a means to improve patient outcomes. Now I'll turn it over to Michelle to get us started.
Great, thank you, Chris. Well, welcome everybody. As Chris said, my name is Michelle Schneider. I will be forging ahead to discuss with you today how to overcome patient identity challenges. And many of us are struggling with those challenges. It is a hot topic for sure everywhere we turn. And so I'm going to just do a few little overview slides to talk about the EMPIs in general, patient identity in general, and then we'll get into some more specific details. So in an ideal world, we have one patient, and that one patient has one unique name that isn't shared by anybody else. They go to one ACO for their care. They have one EMR and only one address where we send all of their mail, and it never gets confused. And that is in sickness and in health until death do you part. But in the real world, we know that that one patient is oftentimes sharing a name or a similar name with other people, and multiple patients result from that commonality, and that patient has the nerve to go to multiple hospitals, multiple providers, multiple states and caregivers, and so that results in disparate systems where all of that information is shared, and many EMRs, and multiple addresses. They move, they just go all around, they go on vacation. There's snowbirds who are different addresses for half of each year, and that is, of course, in sickness and in health until death do some of them part. So we really have our hands full here trying to keep track of these patients and sharing and combining data correctly so that we do have one record for each patient so that we can properly care for them, properly document their care. And so that, of course, is a really overwhelming challenge. So we have a patient identity issue across a delivery network. So back in the 90s, when I first started working with EMRs, we had one system, and we were really diligent about identifying a patient. One name, one address, everything, and we were able to fix it because we only had the one EMR. But of course now the patient is sent elsewhere. They go for lab or a consult or a visit for other types of care. And now we're dealing with not just this little hospital. We have HIEs and IDNs, and now that information gets segregated into multiple systems, and it's hard to identify one place for that patient to reside and all of their information. So EMPIs are how many of us are trying to overcome this, and while no one has found the perfect recipe, we're going to talk about ways that we can overcome some of these challenges and what we can do. Some things are really quick wins, and some things are more long-term that it will take us some time to implement, but the fruits of your labor will be well worth it. So as we're talking about the multiple instances of similar demographic information, and that's important. We have same or similar, but similar demographic information on one patient is where a lot of the problems can come in. You have someone named Jonathan, who now goes by John. I actually have a friend who I was chastising her terribly. She was born Linda, L-I-N-D-A, and when she was in her late teens, she just had always felt that her parents spelled her name incorrectly, and she wanted to be L-Y-N-D-A. And so she just changed it. She started using L-Y-N-D-A on everything she did, but she never legally changed it. She just started changing it, and now she's got Linda with an I and Linda with a Y, like all over the place. So it really, I tried to tell her how how scary that is for her health care, and so you have people out there who just don't understand how they are affecting their own healthcare safety and care. So there is software that we all hear about, we all know about, that can employ complex algorithms, and it helps us to determine matching and non-matching characteristics. And we're going to get into some of that detail as well and talk about those things. And we're going to talk about the workflow and how we can take care of the matched and unmatched things, because sometimes it's not only that we match incorrectly, sometimes we don't match because we don't realize. So really getting those algorithms straight is the big game we play, and depending on the region you are in the world or the makeup of your population, it's not always a one-size-fits-all. That's why we can't just throw out an EMPI and say everybody has to use this one, it's perfect. There's a lot that goes into it, and it's pretty interesting. I find it very interesting. Hopefully you will as well, and we'll talk about that as we move through. So using reporting, but also checks and balances. There's some manual work involved in doing this properly. It takes a lot of care and feeding, but it is certainly worth it. So, so we'll get into that a little. So some terminology before we dive right in. Deterministic matching and probabilistic matching. Those are the basic types of matching you hear about, and many of you may have deterministic matching in place. So deterministic matching in its most basic sense is an exact match. So Michelle Schneider, if it doesn't say Michelle Schneider, then it's not going to make the match. So my name Michelle is spelled with 2 L's. If you spelled it with 1, depending, you can have deterministic matching with some basic rules where it could match Michelle with 1 and 2 L's. But that you need to put that in there and have those nicknames. And so there are some basic algorithms you could have even with deterministic, but in general, the most basic definition of deterministic matching is that they would be an exact match. So as you get multiple sources feeding your system, the deterministic matching is outgrown very quickly, and it really is just doing possibly more harm than good, because you're creating so many duplicates that that's almost as dangerous as having nothing. So the probabilistic matching is really where you get into some of the cool algorithms, where you really take the data, analyze it, and develop the best recipe for your population. And that's why when you hear me talking about that, I stress that as we work with folks, because that recipe might be perfect, but as soon as your system perhaps purchases another hospital or an ACO, or you align with a whole new group, you have just changed the ingredients of your recipe. So you need to step back again and look at those algorithms again, because we'll get into this more, but maybe you have a large population of Indian residents, and maybe the name Patel, for instance, is a very popular, common Indian name, and maybe you've just increased the percentage of that based on a geographic area that you now serve. Perhaps a Hispanic population is much larger in an area that you've now added. So you need to consider that in your algorithms, that now you're going to have many duplicates potentially because of the scoring that will be applied to people with the same last name. So you need to account for that in your algorithm so that you're not matching people incorrectly. So it really is a lot of cool math, and analysis that goes into this to make sure that you are doing the best you can do electronically, automatically with your population. Okay, so then we get into this example. I'm sorry, I get gabbing about this, and I'll try and stay on track. The deterministic and probabilistic, you can see here with these two examples, we have John Smith and John Smythe, and depending on, maybe they are the same person. It's the same address, the same city, although the word South is spelled in South Main Street on the first one, and it's S period on the second one. The city of South Windsor has the word South in one and S period in the other, but the state, the zip code is the same. So in a deterministic matching environment, there would be some mismatches there, and that system would not make the match. However, the patient with the same address, city, state, zip, date of birth, first name with nickname recognition, last name with nickname recognition, you could end up with yeses in every spot and make that match. So there are some neat things to see there when you're looking at this example to see how it could help you. Otherwise, this would have ended up in two separate medical record numbers. So this shows that you could decrease that probability. So the advantages of deterministic matching, exact match. So at least you have that. When it's exact, it is very quick to implement and test. It's either a match or it isn't. And there is less risk on the front end. But as I said, the disadvantages or risks, lots of duplicates created. Some of the common registration errors are not overcome. So South and South, say you have a procedure in place. We always spell out the word South. But you have someone who's writing quickly, a new person, whatever it is, and they do S period for South, now that match will not happen. So you need to, consider that. And the cleanup and unmerge efforts can really be overwhelming and hard to keep up with. With probabilistic, you do have a lower duplicate rate, and algorithms allow you to more efficiently match those. The disadvantage is really the time and effort it takes to do the care and feeding and keep up with those algorithms as you add new sources, things like that. So really knowing that there is an investment in that, but as most of us know, one incorrect match that results in a patient care, it impacts an outcome negatively. It could be way more expensive than the staff person it would take to provide the care and feeding. So some other terminology is also false positive and false negative. So as we get into false positives, it would be a match between two records that do not represent the same person. So being careful, again, with those algorithms. I talked about the last names, that if you have tons of people with the same last name and many with the same first name, so we've seen that as well, where a particular large percentage of the same ethnic group, you end up with more matches on names. So if you give too much weight or a match score, so if you'll look at these columns here, if you apply too much weight to last name and first name, and you don't account for some of those large populations of a particular ethnic group with similar naming conventions, you could end up falsely positive matching somebody. And the same is true for false negative. So when you don't match people because you have, maybe the South and South situation that we just saw, where that John Smith would not be matched even though he should be, because you did not have the algorithms in place to manage that. Okay? And what you can do is sometimes change the score as it relates to the naming conventions. The algorithms can be very complex, where you can say, okay, if it's not a match at all, it's totally different. We're going to give one score. If it's an exact match, we'll give another score. And if it's somewhere in the middle, we can apply an in-between number. So you can really get into some neat calculations here that will allow you to really make the algorithms powerful and meet your needs as best possible. So you have fewer, your duplicate rate is much lower. So why does all this matter? What's all the hubbub, right? So patient safety is, of course, top of the list. If you can consider two patients with the same, they have one patient with two MRNs, and the patient has an allergy that is identified and documented on one, and they come in and a new MRN is created and they receive that drug, and there's a history that they reported that allergy, but it's because we created the new MRN, it's missing, could result in a poor outcome for the patient. So things like that. And the same is true for incorrectly matching a patient, where I might have an allergy, then Michelle Snyder comes in instead of Michelle Schneider, but they match me, or an algorithm matches me, and with that other person, and that person my allergy is applied to that person, which could result in a more expensive med, or a med that's more dangerous or requires more care because somebody thinks I'm allergic to, or that person is allergic to the more moderate version of that medication that the patient could have received. So there are some poor outcomes that can occur by not implementing some EMPI methodology. Analytics, of course, are really important. We are submitting numbers for population health. We're submitting numbers for meaningful use, for Joint Commission reporting, anything like that. If you have two people for one person, your denominator is now a 2. You have just decreased your chances of meeting a requirement, because by inflating that denominator, you are making it look like your percentage is lower. So you want to make sure that your number of patients is correct. You don't want each person to have 2 MRNs, because that's going to negatively impact your percentage rate when you are trying to achieve meaningful use. Decision support, certainly that's pretty obvious. Missing information will make it harder to make good decisions, right? And just trust. We need our providers, our stakeholders, to trust the data that's in there, and certainly our patients. If they go into a portal, they're looking for information and it's not there because the MRN with which they sign on to their patient portal is not the one that was used when they were here last, because we created a second MRN, we lose trust. And then, of course, the whole legal piece, identity theft, not to mention litigation if there is a negative outcome. So the main causes, and there are others, but I want to focus on these 3. The main causes of incorrect patient matching are people, and it's not just healthcare workers. We're talking about patients too, as I talked about with my friend Linda. Patients don't understand how important it is, and it's up to us to educate them. So that is an important part of this. So patients and healthcare workers. Processes certainly are a large part of the issue, and technology. And oftentimes the lack of technology, but also technology that is not implemented well or is not receiving the care and feeding in order to make sure that we are doing the best we can do. So some of the human factors in the inconsistent or incorrect patient matching are, a critical trauma situation is very difficult. This isn't something that's easy to overcome, or that at the end of this webinar you're going to be like, oh, we've got this. That will always be an issue. Certainly, if you can get some biometrics, we work with a couple of companies, a couple of EMPI vendors that use retina recognition, palm recognition, fingerprint. So there's a lot out there that you can do. So a trauma situation, certainly that could come into play. Not everyone has implemented that yet or has the budget to do that at this point, but that is certainly one way to overcome that. Language barriers, having your interpreters available. Card sharing, that's patients are their worst enemies sometimes. By card sharing, somebody could get an allergy on their record that isn't really their allergy, or create new, if they don't give the full name and only give the wrong address, anything like that. It can really impact the patient's safety and care. So patients just don't understand. Registrars also, what I'm finding place to place, registrars are really not, historically, they don't feel that they're a valued part of the healthcare team, and they are the absolute most important in patient identity. And I think we need a real paradigm shift in that area, that registrars understand and are rewarded and celebrated when they are doing a good job, because that is the most important time in the patient's stay, when we have the opportunity to identify the patient properly and make sure that we have a good foundation. That's the kickstart of their care, and that really makes all the difference. So making sure that their role is clear and that they understand how important they are. Policies and procedures must be clearly communicated, and we need to hold people accountable. Not in a punitive way that they need to be, fired if they enter someone's name wrong, but hold them accountable and set goals, make sure they understand how they've impacted a patient's care, no matter who they are. Sometimes if they're not a hands-on healthcare worker, they don't feel that they're as important, I guess, in the patient's safety, but they really are. And educating them of that is an important part of this. So some of the things that you could do next week, tomorrow, to improve your EMPI process is to start with registrars. That really is the quickest, most impactful thing that you can do right out of the gate. Do they know their value? Starting a grassroots effort to make sure that they understand, sharing use cases with them of things that have happened. And you probably have stories there, just even if it's not about patient safety, if it's about the number of hours it took a director of HIM or a nurse or a unit secretary to resolve the issues that are created by one mismatch, lab work on the wrong account, having to move accounts, having to unmerge records, things like that. Really, if you can give a real story, that's more meaningful for people a lot of times, coming to them, talking to them about real stories. So having monthly meetings with a monthly spotlight, a case study, in your EMR, there are usually statistics of, what happened, how many mismatches did we have, how many people's names had to be edited over the course of the last week, how many birth dates had to be edited over the last week, how many social security numbers had to be edited. Those are things that are pretty easy to report on in most EMRs, and those are things you can come back and say, we had to do this many. Every time we have to touch this record, it's this much time. And before we found that, it could have resulted in a negative outcome for a patient. And celebrate the successes too. As you see that number improving over time, as you're increasing awareness and you see that number improving over time, these are things to celebrate at these monthly spotlight meetings where you're talking about case studies. In the beginning, it will probably be more about areas that need improvement, but over time, you'll be able to show that improvement. People want to do a good job. They want patients to be safe, of course. So those are things that we can do really out of the gate. We can do that. Other things that we can do is to improve our policies and procedures, or even create policies and procedures. In a lot of cases, people don't have that in place, so holding people accountable is difficult, and giving them a resource or a reference helps people. So make sure that the expectations of your registrars are clear. If you want them to get a license, not everybody has a license, but maybe your goal is that 100% of the time when a patient has a license, the name will match the license or the insurance card or whatever it is. Usually there is a piece of collateral like a license or an insurance card that is scanned and kept with the record in the EMR for the registration. Maybe do a spot check, maybe check 20 a week. Did that match exactly what was on the insurance card or the license? And maybe that's your goal. And it doesn't have to be that. I'm just throwing that out as an example, but something that is quantifiable, reportable, that you could look at and bring back to your group and again, share successes or set goals for improvement. And educate and re-educate. Again, it doesn't have to be punitive. People want to do a good job. It's just setting the expectations for them a lot of times is really all that needs to happen. And then hold people accountable. And when they have a review, say your goal is we want you to get to 92% of the time. Right now you're at 85%. We want to see some improvement. And mismatches are a struggle, and having a plan for how you're going to handle a mismatch is important. Who do you notify? Who's going to separate those accounts? How are you going to stop everything in its tracks so that you can fix it? And having that documented and something in place, because sometimes people find something, they find it on an off shift and they're like, oh crud, this patient has 5 lab orders already, 2 of them are already resulted, and now I find out that we associated it with the wrong medical record number. What do we do? How do we fix it? And it's always ugly. It's never a pretty picture, but there should be a plan for how to move, who moves. Do you notify lab? Do you notify imaging, transcription? How do we move those things to the correct record? So documenting that, making it available, those are really important pieces to success. Okay, and then once you fix that mismatch, a lot of people are really excited. They wipe their brow. They're like, yes, move on, next thing. But before moving on, as we are in this electronic world, it is more complex than ever. As I said, I started working with the EMR back in the early 90s, and when we had a mismatch, I would painstakingly, undo that account, put it on the correct medical record. I would undo the labs and the RADs, and I would have moved those to the correct one. And it was a little easy then. We were in a little bubble. We didn't have interfaces. We weren't sending things anywhere. Now we do need to consider the ripple effects. So if you change my name, maybe I get married or divorced or whatever it is, and I now have an alias because the system wants to know that Michelle Schneider used to be known as a different name, so that history can be maintained. So it's fine when it's a maiden name, you want it to do that alias, but when you incorrectly matched me and now you unmerged me, we need to make sure that that alias isn't still there, because that's going to affect my score. We're going back to those scores we talked about earlier, where you've got the 10 points added if the last name is the same. Well, an alias out there is going to be 10 points usually as well. We need to remember that, and we want to resolve the alias if we can as well. And not every EMPI can do that. So those are some of the things to really consider as you are moving forward in your search. If you don't have an EMPI and you're moving toward one, consider that if that's something you want to make sure it has in there. So you want to make sure that you understand the ripple effect, and when you unmerge, it's one thing, but removing that match historically so that you can split those records permanently is how some of the EMPIs will, that's the terminology they use. They say resolve permanently, split permanently, things like that. So in this example, we have Michelle Schneider, who's registered for care, and either a registrar or maybe automatically based on some matching score, I am now associated with the record of Michelle Snyder with one L and Schneider spelled Snyder. So what happens is now Michelle Schneider is the one that was just registered, and it actually just overwrites Michelle Snyder. So now I've changed the history for poor Michelle Snyder. Her name has changed, and the alias is now Michelle Snyder. So that's a little bit confusing, but you need to understand and really think about the fact that that's what you're doing. All you're doing is editing the name. Michelle Snyder is still part of the history, so even when you fix this, behind the scenes, the messages are sent to the downstream apps. So Michelle Schneider has updated all of Michelle Snyder's insurance companies, disability, public health reporting, anything out there, any other systems that are downstream and associated even in the HIE have now just gotten a message very quickly to say, hey, her name has changed, and it updates it. But both names are part of the history and part of the alias for that patient's record. So that's a little bit confusing, but it's important to consider as you are trying to map out your process, your procedure for fixing these things, so that you understand this could affect the scoring of the other EMPIs that are associated with your system. In some cases, there's not just one EMPI for an HIE. You might have one in your Epic system, and then maybe your ACO uses Allscripts, and somebody else uses NextGen, and an affiliated hospital uses Meditech. And so you've got a couple of them using some level of matching, even though there is a larger EMPI associated with the HIE. So just some considerations there as you are trying to map out your process and procedure for unmatching or repairing records that were not matched appropriately. So considering downstream systems, educating the team on the process for correction, remove aliases if possible. Not every EMPI has that. And make sure that both accounts are corrected. Sometimes people have a tendency to just fix the one that they're working with, the one that's an inpatient right now, but that historical record needs to be repaired as well, making sure that there's no new or incorrect documentation on that record that was overwritten. Okay, I'd like to just check and see if we have any questions. I'm going to look in the chat area. And I know some of you came in a little bit later. I just want to let you know that there is in the GoToMeeting taskbar, or whatever we're calling it, the dashboard, there's an area for chat. And if you want to enter your questions there, please go ahead and do that. If there's any questions for you, please go ahead and put those in there, and I'll be happy to answer those. Okay. I don't see any at this time, but I'll keep checking, and please let me know if you have any. Okay, so the other thing that we can do that is what I like to call low-hanging fruit is consider our patients, of course, and that is an important component in our success, because I think a lot of times we feel like we have to do everything and can only consider, what we have control of. But educating our patients, they're smart people. We are patients sometimes. We need to realize there's always those that you have a language barrier, you have someone who is a poor historian or who can't speak for themselves very well. But the bulk of our patients are they understand. We educate them. If we tell them how important this is and even cite examples of why this is so important, they will make an effort. I know the people in my family, the people I deal with, if I tell them these things, they now carry their medication list with them. They understand why it's important to not use nicknames, things like that, and things that I try and just educate as the opportunity arises. So do some outreach. Sometimes people are more anxious when they are patients, when they're in the hospital and they're dealing with perhaps a new diagnosis. They're scared. If you can do outreach to folks when they are in their own environment and not in an anxious situation, then perhaps that's a better way to educate them. And set goals, have them carry their ID, participate in biometric registry. A lot of people are nervous about that. They feel like it's something they're being booked or something, but if they can understand the importance of that, if they do come in unconscious, they are confused for any reason, that could help identify them more accurately, and making sure their families understand and know where to find things and can help them speak for themselves. So, and also looking in the portal. I actually had a situation where I had some pain in my foot, and I went and I did have an x-ray where they just wanted to rule out a fracture, and I didn't have a fracture, but they ended up documenting that I had a fracture by accident. And I looked in the portal and saw that and had to file a request for them to update that and change it. So it was in there incorrectly. And so following up, looking at your portal, making sure it's correct, mistakes happen. So it's important for patients to be their own advocates, of course. And then following up with them, re-educating, make sure people are following through, give them the opportunity to ask questions, of course. And sharing with them the decision support, how that helps us take better care of them, how it helps us improve their outcomes and their safety, and making sure that they have one portal. If they have 2 medical records, they will have 2 portals, and that will never end well that I can see. So, if you consider some of the situations of a poor or an incorrect match, you could have someone who has a diagnosis on their record because they were matched with someone who perhaps has asthma on their problem list. If that person had the goal of being in the military, that is enough to keep them out of the military. I mean, these are important things. We're relying on the electronic medical record for everything, and that can be very difficult for a young person to undo if an incorrect match has put a diagnosis or problem on their record that will affect their ability to perhaps get insurance, disability, be in the military, any of those things. So this is a powerful tool, of course. So technology can really help us with a lot of this. We've talked about some of the things that we can do that use technology but don't rely on it completely to really help bridge that gap. And data governance across the enterprise is, of course, one of the things that is really a best practice. So who has the final say? Who is going to, sometimes there's 2 records and you're like, is that person? And you end up digging, you're going to maiden name, previous addresses, all of these kind of more detailed information that's going to help decide if someone is if 2 records represent the same person. So process and reporting, you need to understand your data, of course, and Social Security numbers. If people share a Social Security number, it's either 2 records for the same person or it's a typo. But again, that's going to drive up that score and could make an auto match in the computer that is incorrect. So those are easy things that we can do. A report of everybody with the same social, that's pretty quick to do. You could do that every day if you wanted and have the system spit that out and react to it. Of course, many of us use all 9s or all 1s or all of the same number when a patient doesn't have their social. Get it? So it can also help you find hospital readmits, drug seekers at multiple locations, and I have used in the past a report of significant changes. So I got a report every day of people who had a name change, a first name change. And I just looked through, and it was a visual scan of the report, because there were a lot of them, but sometimes they were very odd. They were, they went from George to, Henry, and it was, obvious that somebody had overwritten that by accident. And so I was able to quickly find a lot of those. Gender changes, sometimes there are, patients who are changing gender, but in general, a gender change is significant and not usually on purpose. Date of birth changes, social changes, not from all nines, but changes that are more detailed. And then just trying to establish consistency in how that technology is implemented. So having disparate and incomplete clinical information on patients, we've talked about that. Billing duplications, incorrectly matching records within a facility or across the enterprise, so mislabels due to incorrect linking, father, son, the junior, seniors, that type of confusion. Those are some things we need to be very careful about, making sure the junior is documented, the senior is documented, and also that deterministic matching, educating your team. This is what we have right now, so beware of that. It is so important that you write Jonathan if it's Jonathan, and if they say John, ask them to tell you, is it Jonathan? Is that your legal name? So we can use analytics to really help us with a lot of that, and that's what Iatrix Systems does. We have a free assessment that we do, and you probably have received the invite to that. And I'm going to talk a little bit about that, how we can take the data that's in your system right now, and we can pull that in and analyze it and present you with a report. Now, sometimes people just need that detail to decide just how bad is it, what is our duplicate rate, and that is a really powerful number that allows you to know how bad is our matching, how is our data clean or dirty, basically. And I know Laura has just put in the chat a way that you can request the free assessment if you would like to do that. And we've been doing this for quite a few of our clients, and we take all of that data in, and I'm going to bring you through some of the data that we provide as part of the free assessment. And this is basically your report card. How is our data? How well are we doing with our matching? And then the next level of that, once you receive the report, there are 3 different levels, really. You can purchase the data that all of the analysis we've done, and you can take care of the records yourselves, and you can remediate those, or we will remediate it for you. That's the second one. We will provide you with a quote based on the number of records that require remediation. And then the third level is we have partnerships with EMPI vendors, and we can educate you on those and give you the opportunity to learn about them and decide if you would like to invest in an EMPI. But even at the end of the free assessment, the report is yours. We give you a really pretty PowerPoint of all of your information that you can use to go to your leadership to hopefully have what you need to get champions behind the work effort involved in resolving that. So, or maybe you don't need it. Maybe you're doing great, and you can celebrate that. So the analytics, besides duplicate rate, we'll talk about matched records and record sets, generic records, so name, social, date of birth. Those are some things like baby girl, baby boy is a generic name, all nines is a generic social, and 1101 is a common date of birth when you don't know someone's date of birth. Field level analysis, I talked a minute ago about maiden name, previous address. Those are some of the things we get into, and how many, how good is that data? Are we good about getting mother's maiden name? Are we good about getting previous address, or what's the percentage of those that are missing? So that's an interesting little factoid too that I think people are surprised at sometimes. And I talked about geographical, regional challenges, people, a large population of a particular ethnic group that can affect your scoring and your algorithm. Human errors is a good way to just know where your errors are happening. Are they from a certain source? Are they certain registrars? Are they certain types of issues? And then you can show improvements over time. So we talked about that, celebrating those successes as you are seeing those improvements. So a lot of good stuff can come out of the analytics that you can provide. So understanding your system is really the first thing that you need to do. Where is all the data coming from? So people don't, when they sit down to think about it, they realize how many sources are feeding their demographic data. So of course you've got your registration in your acute care system, your ambulatory system, and then some people are also receiving patient information from interfaces. So ADT interfaces, another EMR, you've got physician practices, a lab system, or radiology, something like that. They might be receiving flat files or order messages that create patients in their system, or consuming CCDs. Lots of options here that can absolutely affect your matching. And you need to realize the last one in wins. So back to Michelle Schneider, the last version of that patient's name is going to keep overwriting what's there. And considering, have you ever converted from another EMR? So our data will show that too. You'll see that. That's kind of neat as well. And what those records look like. Were they clean or dirty when we purchased that little physician group and their EMR was maybe not so tidy? When we brought those patients in, boy, it really had a negative impact type of a thing. So you can see that type of information with these analytics. And how are those MRNs formatted? If they're different, it can affect it. So just understanding if the data is good, is it complete and consistent across the exchange. All right, so understanding your duplicate rate, potential duplicates, close but not quite right, simple name differences, we've talked about some of those. I would love the opportunity to talk with you in more detail. I can be reached here, my phone number at 978-805-4143, or my email is michelle.schneider@iatric.com. And we would love the opportunity to talk to you about the free assessment if it's something you're interested in or would just like to learn more and see if it's a good fit for you.